Good morning. Thank you everyone for coming to Medical Grand Rounds. I have the pleasure of introducing to you today Dr. Jeffrey Probstfield. Dr. Probstfield completed his undergraduate degree near here at Pacific Lutheran University, his medical degree at the University of Washington, and after which he attended graduate school at the University of Minnesota and the Department of Pharmacology. He stayed at the University of Minnesota where he completed his residency training and further trained in clinical pharmacology. Now Dr. Probstfield is professor of medicine in the Division of Cardiology, adjunct professor of epidemiology in the School of Public Health, and furthermore is director of the Clinical Trials Division K-12 and co-director of the Research Education Corps. Dr. Probstfield is well known in the cardiology division and his awards are numerous. His awards include Fellow of the European Society of Cardiology, Fellow of the Society for Clinical Trials, and recipient of the Outstanding Achievement in Clinical Cardiovascular Research Award awarded from our Division of Cardiology. His bibliography is equally impressive and vast. He has well over 200 peer-reviewed publications and many, many more books, presentations, and abstracts. And he's here today to present his grand rounds, the Origin trial, clear but null results for Glargine, insulin, and omega-3 polyunsaturated fatty acids and CVD outcomes. So please join me in welcoming Dr. Probstfield.
Thank you, Amanda. Thank you, Amanda. You know, after you get an introduction like that, you turn around and say, "Is that really me?" Very generous, and I appreciate it very much. It's always, I've had the great privilege and honor to speak in many places, but I always consider giving this Grand Rounds to be one of the most prestigious things that I do in my professional life. So thank you for allowing me to do this. The topic for today is the final results of Origin, and the title that I selected, I think, will help you understand the bus that's coming down the road. Clear but null results for Glargine insulin and omega-3 PUFA on CVD outcomes. And if Origin is an oblique term to you, then look at the bottom of the slide where it says outcome reduction with an initial Glargine intervention. And I know you've heard me say that I have really lived my life in alphabet soup, and this is just one more version of the same. My disclosure slide. I chose to start this Grand Rounds with a couple of framing slides. And more this is becoming really important to talk about. If you're familiar with the book written by Friedman, Furberg, and Demetz, what I consider to be the best clinical trials book there is, it's understandable, anybody can read it. It helps a little bit if you have some training in epidemiology, but certainly not necessary. But they have a fundamental point at the beginning of each chapter, and when they talking about the overview of clinical trials, this is the comment that these authors make. A properly planned and executed clinical trial is a powerful experimental technique for assessing the effectiveness of an intervention. It's also been called a blunt instrument by one of the former directors of the NIH. Now, Yusuf Collins and Pito wrote a seminal article on why we should do some big and simple clinical trials. And the overarching point from that article is ask a good question, get a clear answer. And I think if we use that dictum for every experiment that we do, we're going to be in good shape. Now, what our goal should not be to do is ask a good question and aim at either a positive or negative result. We've been extremely fortunate over the years to have a number of stunningly positive clinical trials, And more recently, we've had a number of trials which have been considered to be negative. My disturbance with this is don't just dismiss these trials as negative. In almost every instance, there is a wonderful set of, well, there's a wonderful, at least one lesson, and in some of them, many lessons to be learned about how we can do even clinical medicine. So let me point to AIM High. I gave the AIM High results before this august body before, and you will recall in at the ACC just a few days ago, its bigger brother, HPS2 Thrive, was given. The endpoint in both of these was CVD, both of them spectacularly null. Some people would say negative and dismiss them. But I would suggest if we take those along with the Dell outcome study looking at CTEP inhibitors, the question comes firmly into mind, does manipulation of HDL, is it going to do anything to either CHD or CVD results? And so that remains an open question. But that's a very important lesson to learn because we've been thinking all of these years, reducing LDL is very powerful and positive. Raising HDL, certainly from all the observational studies, should help as well. Well, maybe not so much. There are over 100,000 participants that have been in vitamin E trials for CHD-CVD, spectacularly null. Now, the interesting thing is we also did a 32,000 participant trial in prostate cancer called SELECT, probably not terribly familiar to some of you, but nonetheless, a huge trial that was done. I was very honored to be involved in this study. It was null for both vitamin E and for selenium. I'll say more about that in a moment. But the 5-year follow-up of SELECT was just published in the JAMA, I believe in December of this last year, which showed that not only did it continue to be null, but in fact there was an increased incidence of prostate cancer in the group previously treated with vitamin E. So we really need to pay attention to the signals that some of these trials are giving us. Selenium, as I mentioned already, the factorial, if you will, in the SELECT trial, also a null result. Now, you may also recall that the infectious diathesis of arteriosclerotic disease and cardiovascular disease has also been investigated extensively. The common intervention has been azithromycin. It's not been exclusively that, but that certainly has been by far and away the most common intervention. Again, very substantially null across the board. Odds ratio, I think, almost exactly on 1. So the infectious diathesis, at least for that particular kind of infectious organism, really thought to be null. All had. Everybody had great expectations for this study, which had 44,000 participants in it. Becky Litter was one of the people who was very much involved from our standpoint. All had was spectacularly null, except that it strongly suggested that doxazosin should not be used at all, and for the lowering of blood pressure, maybe for improving the flow of in the urinary tract, but not for blood pressure, maybe only a 4th-line agent, but that the calcium channel blocker actually was associated with a substantial increase in heart failure, okay? Now, it was less associated with preventing heart failure than was the diuretic, if we're completely fair. Accord, a trial that cost over $300 million, practically all the arms were null, but it did show us some things, and probably the most spectacular lesson that we learned out of it was that lower is not necessarily better. Remember the blood pressure arm, 140 versus 120, and we really didn't get an improvement with 120 over 140. One of the commentators at the ACC when these were given, said, you know, there are a lot of primary caregivers that are wiping their brows because they don't have to put the fourth medication on for blood pressure, and they don't have to press quite so hard for diabetic control. So there are some very important lessons that we should learn from trials that are null, and I really prefer that, and I will encourage you to use that term. So the trial for examination today is Origin. I was fortunate enough to be involved as one of the presenting members at the ADA last year. There were 6,000 people in the audience, 1,000 people standing around the room, and there were 1,000 people that the fire marshals would not let in. So this was certainly, I think it was the biggest audience that I've ever had the privilege of speaking to. So I think you'll see the importance of this as we go along. So what was Origin? A large international controlled trial in people with new or recently diagnosed diabetes, impaired fasting glucose or impaired glucose tolerance, and an additional risk factors lasting, it was meant originally to last 4 years as part of the intervention. In actual fact, because of the delayed issues in the DCCT and the suggestions from Accord that maybe we would have been better off even going longer. About 3.5 years into the trial, we convinced our good friends from Sanofi Aventis, you know, it would really be a good idea to follow these people for another 2 years. To their great credit, they did not see any outcomes. They did not see the event rates, but they signed the check for an additional 2 years. And I think you'll see, as you see the results, this was a courageous but very important step on their part, because I think you'll be convinced that the results are extremely impressive. It was to assess the effect of 2 independent therapies and on CV and other outcomes in over 12,000 individuals. We titrated basal insulin using insulin Glargine, and there was 1 gram of omega-3 fatty acids in the factorial, and I'll show you more about that in a minute. I'll show you the rationale design and the baseline characteristics, and then the results today. So for those of you who have suffered through some of my previous presentations here, you'll remember that we commonly have been involved in trials that have factorial designs. This is not an exception. This is a factorial design, and the MEA stands for a main effects analysis. So in this trial, we're comparing all the cells with Glargine versus all the cells with standard care, and we're comparing all the cells with omega-3 fatty acids in them versus all the cells with placebo in them. So this is obviously how it plays out. The standard care was just that. Patients were treated according to their private physicians, using whatever the physician chose to treat diabetes with. They could not use insulin, at least to begin with. And if they decided that before the end of the trial insulin was absolutely necessary for treatment, then they were not allowed to use Glargine. Okay? So we attempted to keep this pristine as possible. And you can see the dose of omega-3 fatty acids. You can see when the recruitment took place, and you can see when the final study visits were done, and then excuse me, the median duration of follow-up. So what were the questions to be entertained? So for the Glargine arm, in high-risk people with IFG or early diabetes, IFG-IGT or early diabetes, does insulin replacement therapy targeting fasting normal glycemia, 5.3 millimole or less than that, and 95 milligrams per deciliter, with insulin Glargine reduced CVD outcomes more than standard approaches to dysglycemia. And in the factorial, in high-risk people with IFG, IGT, or early diabetes, does adding 3 omega-3 fatty acids reduce CVD? And we were also very interested in whether or not we could prevent diabetes. So in type 2 diabetes, IFG, IGT, in diabetes, IFGT and IFG, that we have insufficient insulin states with regard to the maintenance of normal glucose. There have been a number of trials recently. The ADOPT trial using metformin and TZDs. There have been smaller trials using various administrative forms of insulin, but virtually all of these are relatively small. And finally, more recently, a lot of people in the audience here were involved in the diabetes prevention program, and there are also other trials where TZDs were used. DREAM, I presented that here a number of years ago, and Acrobos, stop-NITM. All of these suggesting that perhaps we could prevent diabetes, people who were at risk for getting diabetes, from actually becoming overt diabetics. So really it's a little bit of gilding the lily, but you can see as the fasting blood sugars go up even before, certainly in the very early parts of when you might be considered to be a diabetic, you start having an increase in risk. So it doesn't just magically happen after you get to relatively higher levels of glucose. Along with that, you can see people who are in various diabetic states. In the top panel, you can see people who are allegedly healthy, normal glycemic. They have little excursion of glucose during the day. If you look at the corresponding line for free fatty acids below, relatively level. Then you look at mildly diabetics and you see greater excursions in the glucose, and in the top line, substantially greater excursions. This an issue which we are attacking in a new trial that we're doing called flat sugar. So you can see also that as the free fatty acid level goes up, the hazard ratio for sudden death actually goes up. The left-hand panel shows you the uncorrected data, and the right fully adjusted, and you can see there is a host of risk factors or variables in the lower right-hand corner there for which the data on the right are adjusted. So the omega-3 question in high-risk people with IFG, IGT, or early diabetes, does omega-3 PUFA supplementation reduce CVD? And why should it? Well, a number of actions are attributable to omega-3 fatty acids. Inhibition of platelet aggregation, there's an anti-inflammatory effect. It decreases Lp(a) and triglycerides and incidentally free fatty acids. It appears to have antiarrhythmic properties, lowers blood pressure and heart rate modestly. Increased fish oil intake has been linked to reduced coronary heart disease and sudden death in some population studies, some of the best done, the Leiden study. It's not been well studied in diabetes, IFG, or IGT. So what have we learned from other studies in which omega-3 fatty acids have been given? Well, the original GISI study, which I'm not showing you today, had about a 17 or 18% reduction in CHD in people who were post-infarction. You can see this is another population in which the GISI group looked at patients who had heart failure. There's an important piece in this slide and a lesson to be learned. The GISI group had as part of their protocol that they were going to adjust the final result for heart failure hospitalization in the previous year, prior pacemaker insertion, and aortic stenosis. Well, they were cautioned by their DSMB not to publish the adjusted results, but to publish the unadjusted results. Okay? They did not follow that suggestion. So the published results are, as you can see in the yellow, the hazard ratio is reduced to 0.91. about a 9% reduction. Risk obviously substantially reduced from the original observation, but if you looked at the unadjusted result, it's 0.93, which, incidentally, is not statistically significant. It's interesting because we'll look at some things later which help to frame that a little better. So what are the inclusion criteria? People above 50, at or above 50, they had to be glycemic, and you can see all the definitions there for IFG, IGT, and then where they could be. Basically, if they were diabetic, they could be on no more than one agent at the entry to the trial. If they were to be at high-risk CVD, they had to have, you may recall, at least 2 of the following. The major outcomes. The insulin arm had 2 primary outcomes with appropriate statistical adjustment for each of them. The first one was CVD death, or MI, or stroke, and the second one had the addition of revascularization or hospitalization for CHF. And then you can see an extensive description of what the microvascular outcome was. You can see very clearly, though, it does not have in it any pictures taken of the, of the retina, and that's a crucial point for many trials in which microvascular disease is being looked at vis-a-vis diabetes. New diabetes are in those without baseline diabetes. There were very specific definitions for that, and we were very interested in that, and then all-cause mortality. The major outcomes in the omega-3 fatty acid were CVD death, and then you can see we had others. One of the chief secondary endpoints was arrhythmic death. Other outcomes that we were very interested in included cancer, angina, amputation for ischemia, CV and other hospitalizations, hypoglycemia, especially in IFG and IGT patients. You wouldn't particularly want to put those people at risk, giving them insulin, cognition, and erectile dysfunction. A number of those studies are still, sub-studies are still being prepared for publication. So the short story is there were over 10,000 patients who had diabetes as they started to be screened. An additional 760 patients were identified as being new diabetics as they went through our screening process at the beginning, where they had to have an OGTT. And then we had 1,450 patients who had either IFG or IGT at the outset. And you can see the original drugs that were taken when these people came in. 40% of them were on no diabetic therapy. 27% of them were taking metformin, 30% were taking sulfonylurea, and other glucose-lowering drugs, 3%. Now, you could be on insulin if you came to the clinic, but you had to be taken off insulin, and there had to be a period where you washed out before you could be put in the trial. You can see the median entry FPG is 125, and the median HbA1c is 6.4. So 12% smoked, 80% had hypertension, 15% had any albuminuria, 59% had previous CVD. And you can see the concomitant therapy that these people were using. Obviously, many of them had already had CVD, so it's not surprising that you see this cascade of drugs on the right with which they were treated. Average age, 63.5, 35% of this population was female. So what are the interventions? Well, the intervention was the same in the IFG-IGT participants as it, was in the diabetic participants. And you were to add evening Glargine to either 0 or 1 oral agent, and you up-titrated yourself 1 to 2 units twice a week with a target FPG of less than 95, or 5.3 millimoles, and you could add metformin to the treatment, and this was to attempt to mitigate hypoglycemia. So for those of you who don't know, I don't think it's completely understood yet, but the addition of metformin to people who are taking insulin substantially reduces the opportunity for hypoglycemia. As far as I know, that's not understood, but it is clearly a fact. In the standard care group, they were screened every year for diabetes. The guidelines were based on physician judgment, so patients in the standard care group were treated according to their physician's choices. No insulin until they were on greater than 2 oral agents, and they, again, could not use Glargine. So how did we do? Permanently stopped about 19%. The reasons for stopping, just plain refusal, and 90%. We could have done a better job in sort of sorting that out better, but we didn't. Hypoglycemia, 4%. Interestingly, weight gain, only 0.3%. Hyperglycemia, 0.3%, and other reasons, 5. So the adherence was really quite amazing in the omega-3 fatty acid as well. You can see 96% at the end of 1 year, 93% at the end of 3 years, basically 91% at the end of 5 years, and at the end of the study, 88%. And I'm not quite sure why it fell off in those last 2 years so much, but there is some reduction there. So this is the primary outcome measure for the omega-3 arm. If I use the word superimposable, I hope I'm not overstating the case. Fatal arrhythmia, superimposable. Now this flies in the face of a number of other substantially large experimental pieces that have been done. I only point out to you, only is it not positive, the hazard ratio actually is 1.10. I'm not going to make too much of that, but the important point here is there isn't even a trend in the favorable direction. Now, there's been a meta-analysis done of all the trials, and if you look at the issue of cardiovascular death, which obviously would be pretty solid and difficult for people to dispute, there have been 11 previous trials in which this has been measured. It's 0.93 if you use the JISI heart failure as 0.91, and it's 0.93 if you use JISI heart failure 0.93. The origin results added, you can see 0.98. So the meta-analysis now shows that you have a relative risk of about 6% reduction, and the the confidence intervals are just at 1. Obviously, that would be slightly different if you use the unadjusted rate for JISI heart failure. So if you walk into Costco, this is what you see. This is the beginning display in the Kirkland Costco. If you are not recognizing this, this is a big stack of fish oil. And in this aisle that you come into, not only is there one display of fish oil, there are about 3 different kinds of fish oil. So what does it say on these displays? Supports heart health. So I'd like to see the evidence for that, but it's a little wanting at this point. So how about the Glargine arm? I'll just remind you of the question very quickly. In high-risk people who have IFG, IGT, or early diabetes, does insulin replacement therapy targeting fasting normal glycemia, and you can see the definition, with insulin Glargine reduce CVD outcomes more than standard approaches to dysglycemia? Now this shows you the percentage of people that remained on insulin therapy as we went through the trial. In the purple at the top, this is the arm assigned Glargine, and at the bottom, this is the arm assigned standard care. Now, there's an 11.5% portion of the standard care arm that's on insulin. I can only tell you that probably less than 10 people in that arm took Glargine during their time in the trial. So this shows you what happens as you start this up titration. You start at 0 units, and you can see by the first year you're at about 0.31 units per kilogram, and it goes up to about 0.4 units per kilogram. And this represents about 28 units on average for a person who is 70 kilograms. Now, what does this interquartile ratio business mean? It just means that, you know, at the bottom of this, at the bottom of these excursions, you know, there's only 25% below that, or if you look at the top, there's only 25% above the top of that. Again, here you can see what happens with the median FPG levels, and this you can see that the standard care group in the diabetics starts at 124, comes down to about 119 at the end of the trial. It's 123. Very interestingly, the stability of the glucose levels in the treated arm is almost stunning. It goes down to less than 95 and basically stays there for the entire period of the trial. Again, you can see the interquartile data. And this shows you the median HbA1c levels. It's a little bit distorted, but you can see the HbA1c levels are also relatively stable during the entirety of the trial, and the interquartile ratios. Okay, so what did we see? Well, again, I think that this fulfills the definition of superimposability. You have a hazard ratio of 1.02. I'm not going to show you the second co-primary, but it is virtually identical to this one. All-cause mortality, similar. And any cancer, 1.0. Now you can say, so what? Big deal. Well, it is a really big deal, and I'll explain more in just a moment. But the important point here is that this is an incredibly robust analysis. You have well over 950 outcomes here in this analysis. So your data set is robust. There is a difference of 1 cancer between the two groups. Okay? So why was this important? Well, I know you can't read this, but I just wanted to show you that there was a publication in 2009 that was done on a German insurance data set which had over 125,000 people in it. And the gist of this analysis suggested that there was an association between taking insulin and the frequency of cancer. Not only that, it was specifically aligned with the taking of Glargine insulin. The association of some of the authors has been questioned. Now, there was a meta-analysis, substantially smaller data sets, but the trials that had been done with Glargine were also analyzed, and the strong suggestion was that the hazard ratio here was 1. So the secondary research question, we were very interested in whether or not Glargine insulin could reduce the frequency of patients who went from IFG or IGT to diabetes. Remember, we had over 1,400 patients in this. You can see what happened to their insulin levels as they went in. As you can see, it's about 5 units of insulin lower at all time points, so that at the end of the study, there's a median administration of insulin of about 23 units for a 70 kilogram individual. And here is what the FPGs look like. Again, a stunning stability in the FPG level throughout the entirety of the study. So how about new diabetes? Well, there were very strict definitions for this. If you had been put on anti-diabetic therapy, or if you tested positive in one of the oral glucose tolerance tests that was done after the cessation of therapy at the end of the trial, then you were counted as a new onset diabetic. And you can see, if you compare the two groups, there's about a 28% reduction. And if you look after the second GTT, the new diabetes in the yellow, that was the defined in the protocol primary analysis for this part of the trial. If you look after the second OGTT, it's similar. It doesn't quite, it's just on the border of statistical significance. And there was a way to include other cases which were a bit uncertain, and that analysis suggested that there was a 31% reduction. So this is insulin administration after 6 years, titrated to relatively normal FPG levels. The only problem for me is, what's the durability of this? The last OGTT in this experiment was done not more than 100 days after the cessation of therapy. So you can see where one might have some concerns about exactly how long this effect would last. There's always a follow-on study. You know there's going to be a follow-on study, right? So we're doing now what's called Rationale. And hopefully at the end of Rationale, we've been funded for 2 years, there will be a subset of patients in which had either IFG or IGT who remained free of diabetes, who will be tested once again to see if this effect really has durability. How about hypoglycemia? Well, the first thing and the overarching comment I want to make is, in the patients who had IFG or IGT, the rates of hypoglycemia were actually substantially lower than they were in those patients who had diabetes. I don't have the data, but I can tell you that that sort of overarching statement can be made. If you look at any of those patients who had one or more non-severe episodes, 57% in the Glargine group. The interesting thing is, they usually got one episode, and for the vast majority of patients, they never had a subsequent episode. In the standard group, it was only 25. If you looked at those who were confirmed, it was 42 versus 14. You can see a theme here. It's about a 3-to-1 ratio. And if you look at those people who were severe, that is a documented fasting sugar of less than 36, or they had to have help. They either went to the the emergency care, or they had to have help from some other member of the family or whomever. It was 6% versus 2%. Again, about a 3-to-1 ratio. The interesting thing is, if you were concerned about having a hypoglycemic attack when you were driving a car, it actually looks like you had fewer accidents taking Glargine than if you didn't take it. Now, you wouldn't be surprised to know that these numbers are incredibly small, so I wouldn't put much credence in this. How about weight and BMI during the 6.2 years? What am I doing for time? I guess I'm okay. So the mean weight, 85 at the end of the trial in the Glargine group, and 83 in the standard group. You can see what the BMI is. So again, there looks to be a modest weight gain of about 2 kilos. And the interesting thing is that it actually goes down in the standard care group, where you have an effect probably of metformin being manifest here, because people who take metformin frequently get some weight reduction. And you can see that that analysis is in the panel below. So a summary of findings. In the Glargine arm, the first primary outcome, 1.02. The second primary outcome, 1.04. The microvascular composite, which I didn't show you, did not reach statistical significance and was relatively modest. Again, the most important thing which could help us here is retinal photography, and that just wasn't part of the study here. Death, 0.98. Cancer, 1.0. And I have to tell you that when we gave this result, the 6,000 people in the audience exploded into applause. because this thing about the relationship between cancer and the administration of insulin had been hanging over people, and there were a lot of people who treat diabetics on a daily basis that were nervous about this, to say the least. Conversion of IFG to or IGT to diabetes, a 28% reduction. And the summary of findings. Compared to standard glycemic care of people with early diabetes, IGT and or IFG using once daily basal insulin glargine to target an FPG less than 95 for a median of 6.2 years maintains near normal glycemia. And maintains, I think, is the correct term. Stunningly stable. Has a neutral effect on CV outcomes and on cancer. Slows progression of the dysglycemia. You may have noticed that the amount of insulin that people were using as they went through the trial remained relatively stable. Modestly increases hypoglycemia. That's been debated back and forth, but among the diabetologists, that's what my friends tell me is the correct modifier for that. Modestly increases weight. So what are the implications? Supplementing endogenous insulin with basal insulin injection slows progression of dysglycemia, at least over 6 years. Although later benefits or harms cannot be ruled out, exogenous basal insulin main effect over 6 to 7 years is to flexibly lower glucose. Despite lower glucose levels, routine early use of basal insulin glargine is not better than guided-based standard care in limiting serious health outcomes. Very fair. Basal insulin glargine is now the best studied glucose-lowering drug available, and no safety concerns limit early use when needed. Thank you very much. So Professor Lipkin, you may be retired, but your brain is still functioning greatly, so you must have a question out of this one. So the poor soul who was given the task of presenting that at the ADA was Aldo Maggioni, you know, who was the PI of both of the GISI studies that have been performed, and there's yet another one coming.
Jeff, thanks for a great presentation. I was quite interested in the idea of giving the glargine insulin to the people with impaired glucose tolerance to prevent the diagnosis of new diabetes. Yeah. I'm wondering how you sort of summarize the risks and benefits of that. I mean, on one hand, you're talking about giving a medication to somebody who doesn't have a diagnosis for 6 years without impacting their cardiovascular disease or other disease outcomes to prevent a diagnosis that they might end up anyway. Yeah. The relative risk reduction was in the 20 to 40% range, but the absolute risk reduction was really
very small.
10%. Yeah. So the number needed to treat then goes up, the risk of hypoglycemia. So how do you, very complicated math, how do you balance?
So for part of this presentation, your comments, very fair, John. What I really should have is the rates of hypoglycemia in that group so you can see that. The only thing I can tell you is Herzl has continued to reassure us that the hypoglycemia rates in this group is incredibly small, much smaller than anyone would have predicted. So how do I balance it? Well, I don't think everybody's going to rush out and start treating their IFG, IGT patients with insulin. But for those people who can't reduce weight, I mean, the DPP is a stunning result, you know, reinforced by the Finnish study, almost exactly the same amount of you know, risk reduction for converting to diabetes. You know, something way over 50%, there are going to be some people who can't do that, or they can't take metformin, which, as you know from DPP, also prevented. So would somebody consider using insulin in that group? Well, they might, but I would be much more convinced if we were 2 years out and I could tell you that that 22% reduction that we saw immediately afterwards was 22% at 2 years. We have to have that information. Otherwise, to me, it's a, and that was the part that I presented at the meeting, and I cautioned because of that issue. I'm very concerned about what the durability may show. So your question is fair. I don't know how to answer it better than that. Well, yes. This is a question above my pay grade, but I'll try to take a stab. So my diabetologist friends tell me that they think what this will do is put the beta cells at rest. And there is some experimental data to support that. But that's the intention, is to put the beta cells at rest so they don't have to work as hard. And then, you know, one would only hope that if you did that, that you, at the same time, you would encourage these people to lose weight over 2 or 3 years and get their weight down so that they could get the effect of that as well. For this to be the sole treatment of that, I would have a hard time supporting it. Yes, Ed? Yeah. 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 And there was nobody in this trial less than 50 years of age. So the extrapolation to that group is, be careful. Yes,
so, yeah, very powerful studies, very clearly presented, Jeff. Thank you. How does this fit in with the overall picture of what we know about uncontrolled plasma glucose and macrovascular disease?
Jeez. Now you're definitely asking me questions above my pay grade. You know, I mean, for those of us who did a cord and worked our tushies off for, basically a third of our research careers, I mean, the field is absolutely confusing right now in terms of the prevention of macrovascular disease. You may recall that the microvascular examination in a cord actually did show something, but the macrovascular disease from any direction right now is wanting. So I have a great deal of difficulty doing it. The only thing I can tell you is you appear to be able to maintain those glucose levels for an awful long period of time, but recall that they're really pretty constant in those people who were taking the standard care as well. So could we do better with that? Possibly. Yes, sir.
So another great presentation. Thanks so much. And so turning back to the vitamin E, and so
yeah,
the question, or to the omega-3 fatty acid, and so is there something else in fish, or is the fish thing just a association?
But you know, there's a generic answer to that. You know that all the supplements have absolutely gone down in flames, every single one. The supplements. if you look at the natural sources, the Leiden study, for instance, I mentioned earlier, you know, that's a very high fish diet. And the results from that are stunningly positive in a relatively small population. And there are other observations, well, there are more than observational studies. There are other trials in which high fish diets have been used, natural sources of fish oil, which appear to give us quite different results. So natural sources versus go to your favorite health food store. As far as I'm concerned, put them all out of business.
Thanks.
I mean, just we're talking several hundreds of billions of dollars here. And the people that are taking most of these are people who are on limited incomes, believing that they will somehow help themselves.
Thanks.
Thank you all.